I think the advantage of having a standardized approach is that most of the thinking that you need to do is actually done before you're in the case. That allows us to focus on the case rather than reinventing the wheel each time we come in. We've published our experience with ureteroscopic active fragment extraction with the goal of achieving a stone-free state. And we followed the patients out for 5 years. The size of the residual fragments appears to determine the patient's fate. So if there's a fragment larger than 4 millimeters remaining, they have a high rate of recurrence. Less so if it's 2 to 4 millimeters, and if the largest fragment size is less than 2 millimeters, or what we like to achieve of completely stone-free, we see very little retreatment at just 5% at 5 years. And one way to think about this is this would be the fragments that we're considering a success for shockwave. I think the dusting procedure leaves you with fragments in the 2 to 4 millimeter range. We really want to get people stone-free, and that less than 2 millimeters on CT is a stern test. But that's the key, and what I think is most important about the access sheath placement is the ability to achieve a true stone-free state. So our steps to achieving stone clearance, 6 steps. First is to get access, which is what we're going to talk about today. And the important thing to think about with the access sheath is that the size of the sheath really determines the size of fragments you can remove. So 11-13 French, biggest thing you can get out is 2 to 3 millimeters, 12-14, 3 to 4 millimeters, 13-15, 4 to 5 millimeters. And when we're talking about a large volume of stone, that difference between 11-13 and 13-15 is very significant from both the effectiveness of the procedure and the efficiency of the procedure. We begin by clearing all papillary tip calcifications. We extract everything that's mobile, that's small enough to be removed. Again, the access sheath dimensions are important for maximizing the number of stones that can simply be extracted. We relocate all larger stones to a dependent, easily accessible upper pole calyx, and this is where we get the fragmentation done. Then we want to remove all fragments. The most important step of this is having good, secure access, and that's what I want to focus on. This is the algorithm we've developed and employed over the last approximately 5,000 cases. Our only strong indication for pre-stenting is if the patient presents with an active infection. It's a lot to look at as it sits, but let's step through it with a representative case. So this is a 40-year-old gentleman who presented with severe recurrent stone disease. We obtained a CT scan which demonstrated a large obstructing ureteral stone. It was clear that he was not going to be able to pass this stone spontaneously, and we actually made arrangements to have him in the operating room the following day. And this demonstrates that not only does he have a large stone burden, but he actually has a bifid system as well. He's a good patient to look at for the access sheath algorithm because he presents both with a large ureteral stone as well as extensive renal stones. And this illustrates the importance of both intact extraction and fragment clearance. We begin with placing a Benson wire. If you fail with the Benson wire, the next step is a glide wire. If you can't get a glide wire in, you're pretty much looking at a nephrostomy tube insertion. If you are successful with a glide wire, I then replace that glide wire with a Benson wire. In this case, the stone is quite impacted, and we started with the glide wire, and we're able to successfully place this. So our next step is using the 8 French dilator, and this gives us an initial sense of the capacity of the ureter. If I can't place an 8 French dilator after achieving access with a guide wire, I'm done. I'm placing a stent. On the other hand, if we can get the 8 French dilator up, the key component for me is placing the 10 French dilator over top. This really brings us to our decision point. I'd like to talk about that a little bit. So we have a variety of access sheath sizes and lengths, and the choice of that I think is very important. If you can't place a 10 French dilator, you could still potentially use a ureteroscope. Unless it's a very limited stone burden, I would actually advocate falling back to simply placing a stent. If the 10 French dilator goes up with mild resistance, probably shouldn't go larger than an 11-13 French access sheath system. If there's no significant resistance, which is where we find ourselves most of the time, you're looking at a 12, 14 French system. If the access sheath just falls in, that's where we begin to be able to consider the larger access sheath. The access sheath defines the extraction limit. Some of the stone factors that we look at, if you have a large stone, you know you're going to be generating a lot of fragments. Anything that helps out on the efficiency is going to be very effective. If the stone is very dense, getting up over 12 or 1300 Hounsfield units, you know that fragmentation of this is going to be challenging. It's going to make big pieces. The bigger the piece that you're making, the larger access sheath you'll want. When we're dealing with a large number of stones, as we are in this case, again, having a larger access sheath is very important. But if you're looking at just one stone, you may be able to cheat a little bit smaller. Similarly, the collecting system is quite important. For a collecting system that's non-distended, it'll make it very challenging to relocate the stone. And in this case, you tend to make more fragments, and that will be a challenge for efficient stone clearance. So if we know we're going to have a hard time removing stone, again, having a larger access sheath is important. It's very important to consider patient factors. So if the patient is anticoagulated, if they are coming from a distance where continuity of care is going to be a challenge, if there's some other comorbidity, they may have other issues that are being treated at the same time. All of these situations would argue towards a more conservative approach. It just is so important to have a good sense of whether to proceed or not, and Sun Tzu is always right, but he will win who knows when to fight and when not to fight. Many people will think about inserting the access sheath on its entirety, and our approach is to actually begin with just placing the obturator, and this is part of our strategy to really understand the capacity of the ureter. So obturator goes in acceptably well, we can think about placing the entire unit. So take the obturator out of the patient, reassemble, and place the entire unit at that time once you're confident that you'll be able to get it in. With men, there sometimes can be an issue with placing the completely assembled access sheath, even though the obturator has gone in well. The obturator tends to be more flexible than the entire access sheath, and you can see how there's a bend portion right here, which can cause some kinking. So what occasionally will happen is a sheath that seemed to go in well, when try to place it, won't track. And at this point, it's important to look with fluoroscopy down at the bladder level, but if you see this happening, a good strategy at that point is to place a super stiff wire, and at that point this should track up well. So in this case, not only did he have a large ureteral stone, but he also had a bifid collecting system, and within the kidney are stones that required fragmentation, as well as relatively large stones that we were able to extract intact. In this case, we used a 13-15 French access sheath, which was pivotal. Another important issue of this is this patient had a stone burden that might be approaching that, which might normally be handled percutaneously. We were able to do it ureteroscopically from start to finish in 45 minutes. Our average OR time is about 23 minutes. The efficiency of this is due to the access.